Good morning and welcome to MSK again. This is part 3 of our introductory unit in musculoskeletal sonography. So today we're going to talk about sonographic artifacts in MSK and as they pertain to MSK. We're going to talk about ultrasound techniques a little bit, as well as color and power Doppler and dynamic imaging. The first thing we're going to do is go over a little bit in less detail than you would have in physics, but sonographic artifacts in MSK. Now, anisotropy we went through last semester, or last week, but we're going to go through again this week. Shadowing, refractile shadowing, enhancement, increase through transmission, posterior reverberation, ring down, comet tail artifact, and time of flight, as well as beam width artifact. So these are the artifacts we're going to focus on for MSK. The first one again is going to be anisotropy. So in the case of MSK imaging, tendons are the strongest anisotropic reflectors, but muscles, ligaments, and nerves demonstrate anisotropic properties as well. So this artifact rears its ugly head when a highly reflective structure, like a tendon, appears hypoechoic rather than hyperechoic, because the incident sound beam is less or greater than 90 degrees to the tendon. So anything other than 90 degrees, you will get a hypoechoic effect, and that's anisotropy. You can correct that by moving your probe and adjusting your probe so that it's meeting the tendon or muscle or structure perpendicular. Posterior acoustic shadowing is our next one. And you're going to get that with the same thing as you would with a stone in the gallbladder, let's say. So the beam is reflected mostly by this strong reflector. And some of it may be absorbed or refracted. And what you end up with is an anechoic area deep, or shadow deep to the interface that you're hitting. You get this with bone and calcium, some foreign bodies, more or less depending on what the foreign body is made of, and with gas as well. You get a nice clean shadow with small radius curvature or rough surfaces, or a dirty shadow with larger radius of curvature or smoother surfaces. So here's a bit of an example. This is a myositis ossificans. We'll talk about that later. So it's calcium within a muscle, and it's got some posterior acoustic shadowing in behind this strongly reflective calcium within the muscle itself. So muscles from here to here, and then you have this calcium and this strong shadow in behind, because a lot of the sound is reflecting back. Refractile shadowing is a critical angle shadowing, or it's also called edge shadowing. At the edge of curved surfaces or highly curved surfaces, you're going to get this kind of artifact. Because the incident ultrasound beam is both reflected by the curved surface and often refracted by different tissue types making up the curved surface. None of the incident sound rays striking the lateral margin of the curved surface return to the transducer, and this results in a lack of echoes or shadow deep to the lateral borders of the structure. So here we have a curved surface right here in this. It's also enhancing, but you've got a curved surface and you've got this little shadow here caused by that artifact. Same thing happening here. This is a scar. You can see the shadow running through, and that's refractile shadowing, think curved. Posterior acoustic enhancement or through transmission. You're going to get the sound beam moving through this substance, and you're going to have enhancement in behind here. So you've got this nice enhancement pattern in behind things like cysts, or you can even get it sometimes with a complex type of collection. So typically enhancement occurs deep to fluid-filled structures because the ultrasound system applies the same TGC to all returning echoes. So unless the operator intervenes, then you would show acoustic enhancement. Posterior reverberation can be in the form of a ring-down artifact or a comet tail artifact. So ring-down is a series of reflective echoes, and it's more continuous, deep to the structure, and this happens with metal surfaces, and that's the difference between comet tail, whereas comet tail is a short segment of posterior bright echoes, and it narrows. So it narrows as it goes further from the source of the artifact. And this is seen with soft tissue gas. So ring down with metal surfaces, and you'll get that continuous deep to a structure. You'll get these reflections. But comet tail narrows down, tapers, and that's seen more with things like soft tissue gases. Posterior reverberation. So the initial sound beam transmits and it returns, but you get delayed reflections from strong tissue boundaries. So if you have bone, and it'll result in a linear artifact that decreases in intensity with depth. Reflected sound gets superimposed over the primary signal, so adding to the distracting information to the image. So this is going to be an example here. So you see the bone here is the strong reflector, and then reverb, reverb, reverb. Time of flight artifact, or speed of sound. They occur when returning sound waves has passed between two tissues with markedly different speeds. So it's a misrepresentation of return time, and that results from an assumption that the speed of sound is constant at 1540 meters per second, which it not necessarily is. So two different tissues. Time of flight artifact. So if the speed of sound less than average in tissue, the artifact appears to be farther away from the transducer. So the faster the speed results in artifact being closer to the transducer on the image. The creation of this type of false information occurs most commonly when imaging obese patient at a muscle-fat interface because of the differences in tissue. So here you have an example. It's fat, skin, muscle, and you've got the speed of sound artifact, so it's not returning at the same speed. Beam width artifact is also known as volume averaging. So the beam's too wide for the object being imaged, and it's corrected by adjusting your focal zone to the level of the object of interest. So if you bring that focal zone up to the level, it should correct that. A strong reflector located outside of the main ultrasound beam can generate echoes that are detectable by the transducer, so you get that artifact. This happens with small calcifications, so the large beam width eliminates the shadow as well. So how do you fix these artifacts? Well, anisotropy, you can heel toe, rock the transducer. You just want to maneuver the transducer to make sure that it's perpendicular to those fibers. Reverberation, you can use a standoff pad, or you can change the angle of incidence. With refractile shadowing, you're going to get compound imaging or tissue harmonics to help reduce or eliminate the artifact, and we'll talk about that. So you'll be sending sound beams in at different angles. If you don't have compound imaging, you can change your window, change your angle of approach. Time of flight artifact, you can change the angle of incidence. So I would like you to have a look and read through these two articles. They're very good. Talk about the artifacts we just talked about. So ultrasound techniques. We're going to talk about new technologies, or technologies, I guess they're not that new anymore. We're going to talk about spatial compound imaging, tissue harmonic imaging, and extended field of view. And these are common things that we use in MSK. So compound imaging is the beams that are produced at several different angles. So the information is combined and it forms a single ultrasound image. So it improves your definition, your plane definition. And your disadvantages to this is that it has a smoothing effect. Motion blur is likely, and you can reduce artifact produced by foreign bodies or even calcium sometimes with it. This happens often if you're looking at kidney stones and you put on your spatial compounding. You don't see any shadowing echogenic foci. Well, take it off, and there you go. You can send a pure beam in, and you'll see a shadow in behind the calcium. So this is what your beam would be doing. It's basically coming in at multiple angles instead of straight. And then it compounds that digitally, and you get a composite image, essentially. A clean image. Tissue harmonic imaging, or native tissue harmonic imaging, as it's also known, is a relatively new technology that allows us to reduce image artifacts. It reduces speckle and clutter and side lobes, especially in the near field. So it's good for effectively looking at cysts and clearly defining solid or complex lesions. This technology is especially useful in abdominal imaging and echocardiography, but we do use it in MSK as well under certain circumstances. Harmonic imaging utilizes multiples of the transmission's frequency, with the first harmonic being the transmission frequency itself. The second harmonic being twice the transmission frequency, and so on and so forth. So for the sake of simplicity, imagine a 2 megahertz transducer. Okay, imagine a 2 megahertz transducer generating a sound beam at its native or fundamental frequency of 2 megahertz. So conventional ultrasound technology forms images from this fundamental frequency as echoes are reflected by tissue interfaces. Now, contrary to the transmitted or incident ultrasound beam, the reflected ultrasound beam is complex, containing multiple weak harmonic echoes at 4, 6, and even 8 megahertz, as well as the fundamental frequency of 2 megahertz. So these weak echoes are called harmonics and are the key to improving the image using tissue harmonic imaging. So it's important to understand that harmonic signals are not present during the transmission of the fundamental frequency. They form within the tissue due to nonlinear sound propagation. By utilizing a higher frequency received harmonics to generate our image, the image is improved as both axial and lateral resolution improve at higher frequencies. Now, unfortunately, every beneficial effect of new technology is accompanied by a few disadvantages. So, tissue harmonics is not exempt to this. There are two main disadvantages. First of all, the depth of penetration suffers. To some extent, the use of broadband transducers minimizes the effect, but the second disadvantage is you do lose some of that, the gray matter. It gets very black and white. You can see here it's being used to delineate. This is a stump, okay? This is an Achilles, it looks like. So this is a stump of the Achilles. It's torn and there's fluid in here. So it's delineating the margin of the tendon here. You can also delineate borders and edges with this. Extended field of view is a commonly used technology when we deal with MSK. It looks like the old compound B scanning with the articulated arm, you know, and that was popular in the 70s and early 80s. So back to that, if we use the dedicated computer and high-speed video image processing hardware, extended field of view imaging allows the examiner to create expansive or global views of anatomy. You can often zoom this view and you can measure on it as well. And it gives you that global view, that global sense. So it combines image information obtained during a real-time scan to form one long composite image, kind of like your panoramic view when you use your camera. And it allows a global view or imaging of an entire structure, no matter the length or width. So it's good for things like large abnormalities, tumors, or tendons, for measuring, let's say measuring big, long things, or let's say proximal extent of a tear in relation to an insertion, or displaying, communicating ultrasound findings and clarifying what you see in a global sense to the radiologist. And this is an example of the extended field of view. This is an Achilles again. This is the insertion onto the calcaneus. You can see here, there's a tear here, here to here, and you can see how far the tear is. You get a really good global sense of what's going on. There's soleal down here, so we know approximately where it is. Now they're used, this is a finger, compartment 6 of the wrist, and you can get an idea of the synovial thickening and how it appears around this tendon. So next we're going to talk about dynamic imaging. And that's a big advantage that we have again over conventional imaging, such as general X-ray or CT or MR. So we don't see necessarily globally like they would, but our advantage is we can look at something dynamically. You can use it to see if something is soft or hard, compressible, non-compressible, and you can use it as an ultrasound guidance procedure. So you can actually watch a needle and put it where you want it by guiding it. And you can assess a reaction to movement. What's causing the pain? So if the patient comes in with an arm abduction issue and they have pain with abduction, you can watch the abduction and see if there are things pinching, causing that pain. So ultrasound, I'll talk about guidance first. So there's diagnostic and therapeutic. We do it for a lot of things like neck, chest, abdomen, retroperitoneum, pelvis, anything really. And today we're going to talk about musculoskeletal. So in ultrasound guidance, you're either giving something or you're taking something, if you think of it that way. And this is Sohail here in the picture. So things you can do with guidance in ultrasound. In MSK, you can administer medicine like a steroid. You can do barbotage, and we'll talk about that a bit later. That's when you go in and break up calcium within a tendon. You can do a lavage, you can do an aspiration, you can do a biopsy. It can be therapeutic or diagnostic. So you have continuous real-time visualization of a needle, and it allows for adjustment of the needle as needed during the procedure so that you can make sure that it's in the right place. And it's all done under sterile technique as well. So your role as a sonographer is to locate pathology, determine various approaches. The radiologist does this as well, but you're oftentimes a team working on this. You can offer recommendations for best and safest needle path. You can use your scanning skills to optimize the image for them. They're all gloved up. You're going to adjust things on the machine while they're gloved. You're going to use Doppler to ensure that no vessels are in the path of the needle, so you don't want to poke a vessel. That will cause a nice hematoma, and then you won't see anything. Or worse yet, you can cause the pain to the patient. You can place the patient in various positions. That's your job too. And you're also going to be preparing the sterile trays and the supplies needed for the biopsy, making sure that all the forms are available, consent forms, lab forms, that type of thing. So here we have the needle here coming into a little mass. Okay. And they're going to take out, in this case. So they're going to take out some tissue, put it into formalin or some other kind of liquid to preserve it, and you're going to send that off to the lab, and they're going to come up with a result from that in a couple of weeks. Here we're administering medication. This patient's having pain, so you want to inject some steroid in there. You can see a nice, has this comet tail artifact. What kind of artifact is this? Think about that. You can go back and look. So you've got your needle here, and there's the tip of your needle. You can even see the lumen of the needle right here. There's a mass right here. I'm going to go in and we're going to sample off by jiggling the needle inside and grabbing some cells to send off to the lab. So color and power Doppler. So we're going to talk about perfusion, inflammation, and neovascularity. These are three things we look for when we use the color and power Doppler in MSK. So just for an example here, break it up a bit. It's a 63-year-old male, and he had a hard, palpable lump on his buttock. Okay, you can see here on his right cheek, and this is the glute. So they want to do an ultrasound to rule out a gluteal pathology. So you first look at it, and you can see this vague hypoechoic sort of, it's like a clover, like a three-leaf clover here. And I could feel that it was hard, so I was pushing on it. Could have been a collection of some kind, but as soon as you throw some color on, you notice that I noticed it was hypervascular, it's hypoechoic, it's solid, and you got to tell them where it is. So it was within the subcutaneous fat layer and not the glute. So you're going to come across things like this. So this is most likely a mass, a solid thing. It's got a very much vascularity to it. So it's probably a sarcomatous lesion or some sort of liposarcoma versus a fibrosarcoma. And it ended up being a malignant sarcoma. Here you can delineate it. Just put some colors on it to show you exactly where it was. It could blend in very well, but as soon as you put color on it, it kind of helps you. These are tools to help you again. This is an example of an inflammation of the lining of a bursa. So you can see increased vascularity of the synovial lining. This is a Baker's cyst, so it's thick and inflamed on the outside, and inside there's no vascularity, it's fluid, so it's a Baker's cyst. We're confident saying that. So it's not a mass. Plus it was semi-compressible. And here we have some examples of hyperemia and in a synovial hypertrophy situation. So you've got increased synovial tissues growing, so it's inflamed. And you've got hyperemia, so increased vascularity, showing that this is not a collection, it's actually tissue and it's inflamed, so it'll be hot. Here, 2 at a joint, we'll do this with rheumatoid arthritis, checking for inflammation in the synovial tissues around the joints. And you can put color on that to see if it's actually hypervascular, and that's a sign of being inflamed. Right, so now you can also assess movement dynamically. So you want to evaluate the abnormality that is present only when an extremity is moved or positioned in a particular manner. So it hurts when I do this, or move your arm this way or that way, or a certain movement. You can reproduce that movement. And you can actually record it on the machine as well for the radiologist. It saves a tremendous amount of time for the patient, for the diagnosis, for treatment. It's invaluable. So things like dislocation or subluxation, snapping of any kind of tendon, but we do often for snapping hip, or impingement very often. That's included in a shoulder ultrasound. So you can click here for demonstration on your actual PowerPoint. That loads up.
The patient sits, arm by side, examiner standing behind. The probe is placed longitudinally over the anterior aspect of the humerus. The supraspinatus tendon is clearly visualized with subdeltoid bursa above and coracoacromial ligament. The arm is moved from extension through 45 degrees of flexion in order to observe supraspinatus tendon movement under the subdeltoid bursa and coracoacromial ligament.
Alright, so just an example of what you can do with movement. You can also use it to assess compressibility, and that's useful information for the radiologist as well. So you can have things like lipomas, and they're kind of soft and semi-compressible, and you get kind of used to being able to qualify these things as you learn. Cysts can vary, but they're more compressible usually, and you'll see them deform when you compress them. Masses like neuromas or schwannomas, they're hard and solid, and they're not compressible. So you can use that kind of maneuver as well to assess compressibility. So that's it for this week. Next week we're going to have a test on the introductory unit, the weeks 1 to 3. It's going to be 45 minutes in length. It's multiple choice. And there may be some matching answers in there as well. Hybrid work, you're going to use the time to review introductory unit. I want you to reread chapter 1 if you've read it, and read it if you have not read it. Review the images and the videos from chapter 1. There is probably going to be some images on the test itself. You're going to review the PowerPoint presentations that I've given. Then when you come back in week 5, we're going to be starting basic pathology concepts. We're going to do a basic overview of pathology and MSK before we start getting into parts. So we're going to go over muscles and tendon injury and bone injury basically to start with. All right, thanks very much.